Well, welcome everybody. I'm Beverly Tumala. Most of you know me, but I am, well, first I'm the board president of ABODE, and I'm also the chairman of the education committee. And this is our sixth installment of ABODE Academy. And this was idea started way back during COVID in a way to try and keep our people together and kind of be able to offer things when we couldn't be in the house. And it's really blossomed. And as we were alluding to earlier, if you go to abodeacademy.org, there's an education tab, and underneath that are all of our offerings. And this session of Abode Academy is all about grief. And tonight, we're so pleased to have a wonderful friend. It's Dr. Jeffrey Benzick. And if you were in our book club, you got to know Jeff, because he was real instrumental in helping us understand the trials and tribulations of being an intern and a resident, as we read our last book about a doctor who died of lung cancer. Anyway, so Jeff has been a psychiatrist in private practice since 2004 and is currently a consultant psychiatrist to the San Antonio Spurs. That'd be interesting. He is a former United States Air Force flight surgeon, a psychiatrist, and a graduate of the Baylor College of Medicine and of Texas A&M University in 1992, and he graduated summa cum laude. Jeff is also a regular Abode volunteer, inspired by the loss of his dear friend Tom, who we were honored to care for in 22. So some of you may have seen Jeff around the house and helping out. So before we begin tonight, as you know, before we begin any activity at Abode, we try to get centered and just get ready for what we're about to hear and let our hearts accept it. So tonight, I just want you all to settle into your chairs, kind of feel your sits bone on the seat of your chair and your feet on the floor. And just listen to these words about opening your heart. I chose this.
Choose to.
I chose this because of words I hear often from my patients who are grieving and have a difficult time just opening their heart to move on. So close your eyes and hear these words. It's called How to Open Your Heart. Do not try to open your heart. That would be a subtle movement of aggression toward your immediate embodied experience. Never tell a closed heart it must be more open. It will shut more tightly to protect itself, feeling a resistance and disapproval. A heart unfurls only when conditions are right. Your demand for openness invites closure. This is the supreme intelligence of the heart. Instead, bow to the heart in its current state. If it's closed, let it be closed. Sanctify the closure. Make it safe. Safe to even feel unsafe. Trust that when the heart is ready, and not in a moment before, it will open like a flower in the warmth of the sun. There is no rush for the heart. Trust the opening and the closing too, the expansion and the contraction. This is the heart's way of breathing. Safe, unsafe, safe, unsafe. The beautiful fragility of being human, and all held in the most perfect love. So think about a time when you were hurting and you thought you would never feel love again, feel happiness again, and how your heart was closed. And then it opened again. And we're going to learn about that tonight. So open your eyes and let's get ready for Dr. Jeff.
Okay.
Welcome.
Yeah, thank you. All right, let's see if I can figure this out. Share my screen. Let's see here, and we're going to do screen one. I've got a pretty nice setup here. There we go. Can you all see my slides?
Mm-hmm.
Okay. And again, sorry, I am new at this. Everybody can see my slides?
Yes, I can see them.
Perfect. Okay, I'm going to move this over a bit. Okay, well, yeah, I'm Jeff Benzick. I psychiatrist in private practice and still love what I do after, wow, 24 years. Wow. Uh, I really got interested in this topic a couple of years ago when I saw there was a real void in my training in how to approach folks with grief. And you'll soon see why. I'll kind of explain where that came from. But it's only been in the last few years that psychiatry has really looked at what are the differences between somebody dealing, for example, with trauma, somebody dealing with depression, and someone who is grieving. And I'm hoping you'll see tonight that they are really distinct entities that warrant their own very specific approaches. You know, I throw this right out there. I'm not an expert in grief. I am not an end-of-life doula. I'm just a guy who sits in my office and I get to walk through some really challenging times in people's lives and still really enjoy doing that. I'm going to cite a psychologist named Mary Frances O'Connor several times tonight. She wrote a wonderful book called The Grieving Brain, which if anybody is interested in this type of stuff, hey, how does the brain really change, adapt, and grow during grieving? I'd encourage you to take a look at that. And I'd also like you tonight to sort of try and unlearn, at least while we're looking through the lens of neurobiology, try and unlearn what you know about grief. I mean, obviously, when we're thinking about grief, we can't not think about the social aspects and the financial aspects and the interpersonal aspects, but the neurobiology is really quite interesting. And I think it provides a lot of validity to folks. They really feel validated when, for example, as you said earlier, sir, my brain wasn't working. You're going to get to see here, yeah, you weren't kidding. And you might even be able to share with them a little bit more. And this is not common information that folks know about. So let's jump right in. I'd like you, when we're looking from a neurobiological lens, I'd like you to think about grief as a process of learning and yearning. And these are two things that the brain is really good at, right? We're good at learning new stuff, and we're good at craving, yearning, needing. And we're going to talk about the biologic underpinnings of both of these today. And I guess I should have said earlier, in true Air Force fashion, I'm going to tell you what I'm going to tell you, then I'm going to tell you, then I'm going to tell you what I told you. Okay, so we're going to go back to, we'll be reviewing a lot of the stuff, and I'm going to throw out some neuroanatomy you've never heard of. And I do want this to be fun. So if folks have a stump the psychiatrist question along the way, yeah, throw it out there. So we're going to talk about, again, how grief manifests specifically in the brain. And I'd like you to think of neurobiology not as a noun, but as a verb, right? It's stuff happening. We'll talk about the specific brain regions that are involved, but maybe more importantly, not so much about brain regions, but really the circuitry that's involved. You know, your brain is electrical. We like closed circuits. We want things to make sense. And when stuff doesn't make sense, we'll make stuff up to get those circuits closed. You can't talk about the anatomy of the brain without talking about the physiology and the chemistry. So we're going to talk about some hormones too, because they're a big deal, right? We're also going to talk about, again, how grief is different from depression. Just a little teaser with that. If I've determined somebody in my practice is clearly in a state of grief, versus maybe actual depression, antidepressants don't really work, right? It really necessitates a separate and special treatment approach when you're dealing with grief. We're going to talk about what psychiatry now calls prolonged grief disorder, right? Which is a very recent recognition of grief by the psychiatric community. So for the first, like back in my training, nothing. I got zero training on grief. It's only, again, very recently that this is understood that, hey, we better take this really seriously. And then finally, again, we're going to talk about areas for engagement. How do we help people, right, who are dealing with grief? So let's jump right into some neuroanatomy. Okay, so let's talk about the hippocampus, right? I've got a few notes here. I'm gonna keep up with myself. The hippocampus is an area of the brain. It's a very deep area in the brain, as you can see. Located about the level of your ears, but pretty deep. And the hippocampus is involved in certainly a lot of things in the brain. It's involved primarily in memory, the formation of memory, the extraction of memory. And some folks have called it the moral brain, because that's where you sort of integrate your emotions with your memory. Okay, so you can sort of understand why this might be an important part of the brain in dealing with grief. So there's a lot of different kinds of cells in the hippocampus. I want to invite everybody right now to imagine where your kitchen table is. Okay, think about where in your house your kitchen table is. You may be sitting there right now, right? That's right in front of me, Dr. So think about where your kitchen table is. So there are certain cells in your brain called place cells, kind of apt, right? They're where you encode where something is supposed to be, where it's supposed to be situated geographically and spatially. Okay. There's also some cells called proximity cells. So if I were to then blindfold you and walk you around your house and say, what are you close to right now? These proximity cells would light up, because that's where we store information about if we're physically close to something. Now, a very interesting property of the brain is that not only do cells light up where something is supposed to be, but they also can light up if something is missing, right? Certain cells called trace cells. And if something is not where it's supposed to be, you're just not going to feel right. Not too long ago, I bought a cell phone. I brought it over the internet. And when it got delivered, they said, hey, if you want a discount, take your old phone over to the T-Mobile store, right? And I know very well there's a T-Mobile store around the corner. I run past it all the time. So one Saturday morning, I get up, I take my phone over to the T-Mobile store, and it's not there. And that just felt weird, right? I knew it was there, but it must have closed down at some point, and that just didn't sit right with me. We can take rats, okay, and we can put them in a like a little rat hotel, right? I think of like the habit trails we all had when we were a kid for our hamsters, right? So you can take the rats and put them in there, and you can get them accustomed to it. And then you can take a little tower made of Legos. This was actually what was done in the studies, and put that tower of Legos right in the middle of the rat hotel, and get them accustomed to it, and then take it away. And what you see when you scan these rat brains, right, little rat, functional imaging scanners, is that these specific trace cells in their brains start to fire, right? And they keep firing for 11 days. And the scans are beautiful. You actually see the depth and the intensity of the firing reduce over about 11 days. Okay. Now let's kind of relate that to you and me, right? Now, these rats had no emotional attachment, right, to this Lego tower. It was just something that was in their environment. And yet, for 11 days, those cells are still firing, right? Now, let's imagine that's your spouse, right, of 50 years who's now gone, right? And every morning you woke up and you reached over and you could touch them. You knew exactly where they were. Imagine how long those trace cells are going to fire when that's missing, right? So I heard a wonderful definition of grief. I'm going to read it. The quote I read was, when a loved one has been wiped off the map, yet the neurons keep firing despite their target being absent, that is grief. That's almost a purely biological description of grief. So trace cells in the hippocampus of your brain, right? They fire when something's missing, okay? And I validate people when they say, yeah, Dr. Benzick, something's just wrong. Something's just off. They can't verbalize it. I tell them, hey, at least we know that part of your brain is working properly because you're not supposed to feel 100%. But there's a whole lot more to the story. We've talked about rats. Let's jump over to prairie voles. I'm kind of glad that person's hand is down in the bottom of the picture, because then you wouldn't know how big prairie voles are. You might think they're like bear-sized or something, but they're actually little bitty, but the length of one of your fingers. And this, you see on the screen there, this is a little excerpt from NPR, right? If you so choose to, you can go to Learning About Love from Prairie Vole Bonding and find the little 3-minute listen that NPR put out there. Well, anyway, so prairie voles are little rodents, live all over the place, and they come in 2 flavors, okay? Monogamous and polygamous, okay? So certain males are completely monogamous, they bond for life, and others are polygamous, okay? Meaning they just sort of cat around, right, to reproduce. Now, if you take those 2 flavors of prairie voles and you separate them from their most recent mate, or I guess in terms of the monogamous ones from their mate, what you find is that the monogamous ones will expend a whole lot more energy and show much more distress trying to get to their partners than the polygamous ones. And then you can take those rats and you can look at their brains, and it's animal research. People have different opinions about that. But in these situations, you look at the brains of the prairie voles that are monogamous versus the polygamous ones. And what you see in the brains of the monogamous ones is more what are called oxytocin receptors in an area of the brain called the nucleus accumbens. And I promise I'll show you that on a slide. Does anybody know much about the hormone oxytocin, what it's involved with? Just curious. Anybody heard of it?
It makes you feel good.
Yes.
That is absolutely one of the things it does. So oxytocin has a number of different functions in the brain. One of them is milk letdown. Right? So if I am a mother and I just gave birth and I hear my baby crying, or if I'm a wet nurse, right, and I hear a baby crying, oxytocin is what causes the milk to start to flow through the breast. Okay, so that's one function. It's also, frankly, why after sex, that time when you kind of want to cuddle and be close and feel close, that's what oxytocin does. As a matter of fact, in a couple of my autistic patients, we have taken oxytocin, put it in a nasal insufflator, allowed them to take some puffs a couple of times a day, and they actually can show some improvement in social connection. Not always, but in some situations we can. So oxytocin absolutely is involved in bonding, socializing, and connecting. And so again, what we see in the monogamous prairie voles is that their brains, specifically that nucleus accumbens, has more receptors, meaning molecules that want oxytocin. Right? So these monogamous prairie voles, because of those hormones, they want to connect more often. Now let's talk about the nucleus accumbens. Okay, let's go right to it. And here it is in the picture. You see it's a little bit farther forward in the brain, but still very deep. Has anybody heard of the nucleus accumbens? Have any idea what that's involved with in your brain?
No.
No.
Okay. The nucleus accumbens is involved in addiction and reward, okay? When we do something that we really like, that gives your brain a hit of something else called dopamine, your nucleus accumbens lights up. We really like dopamine. An alcoholic who gets their drink, a gambler who finally gets to place a bet, somebody who really likes porn, those things give a spike of dopamine to the nucleus accumbens, and we feel good. Now, the downside of that is when our baseline level of dopamine is too low, which occurs after a spike, we want that level back up. And we'll do almost anything to make that happen, right? That's why you talk to alcoholics or cocaine users, say, why can't you just stop? It's because they want that dopamine activating that area of the brain called the nucleus accumbens. But we haven't been talking about substance use. We've been talking about relationships and connection and being close to somebody. So look at the title of the article I've got listed there. The title is Craving Love, Enduring Grief, activates the brain's reward center. Again, the nucleus accumbens, that's your reward center in your brain. And the title of that article looks like it's something out of like People magazine, right? Well, actually that's out of a scientific journal. And again, an article written by Dr. Mary Frances O'Connor and her colleagues back in 2008. They sought out volunteers who were grieving, right? Because they wanted to look at their brains. And so they recruited 23 women, 11 of whom were considered to have complex grief, right? 12 were considered non-complicated grief, so folks that were actually functioning a little bit better. And they asked them to bring pictures of their loved ones. So they could look at them while they were sitting in the brain scanners to see what parts of the brain were active and changing. Very interesting results. The first is that all of them showed pain-related brain activity. People, when they're grieving, they say that they hurt. They may even talk about increased physical pain, aches, pains, things like that. We're going to come back to that because that's really important. But what they also found was only folks with women with a complicated grief showed increased activity in that nucleus accumbens, correlated not with how long it had been since the loss of the loved one, but how much they yearned, how much they craved, how much they didn't think they could live without their loved one, right? The more they said that they were yearning and craving, the hotter their nucleus accumbens got. They really wanted that dopamine. They really wanted that feeling of this is what it felt like to be with that person. Now, this is one of those areas that I tell people, look, there is a little piece of your loved one with you. Your brain is clearly chemically and anatomically changed by that loved one being in your life, right? And when they're not there, but you so want them to be, that's what grief is neurobiologically. So let's keep going, right? We've talked about the nucleus accumbens and dopamine and how oxytocin affects it. We've talked about the hippocampus and the trace cells. Well, let's look at this pain thing, right? Grief absolutely hurts, not just emotionally, but it can hurt physically. Area of the brain called the anterior cingulate cortex, a little bit more towards your nose from these areas that we've been talking about. Again, study by Dr. O'Connor. Again, people in grief, and in fact, in that study, all of them reported a sense of pain, right? This part of the brain, the anterior cingulate cortex, is involved in multiple areas. How you appraise something emotionally, how you regulate your thoughts, how you deal with mistakes, and also both emotional isolation and physical pain. There was a wonderful study done back in the early 2000s, and the researchers took healthy volunteers, which usually means college freshmen, right? So they took healthy volunteers, they put them in a game. And in that game, it was a group game, but in part of that game, some of the members were socially isolated, ostracized from the rest of the group, okay? Then they stuck everybody in a brain scanner and they looked at what parts of the brain changed. And what you find is when you socially isolate somebody, when you emotionally separate somebody from a group or a crowd or a loved one, this part of the brain lights up, the anterior cingulate cortex. And again, that's the part of the brain that lights up when you're in chronic physical pain, right? These two are intimately linked. So again, somebody grieving says, I hurt. You can now say, I understand. As a matter of fact, all the studies would validate what you're saying. You're hurting right now, and we're going to go through this with you. Now, why do we attach to anything? Wouldn't that be nice if we could be, like the Vulcans in Star Trek, right? Just purely emotion, right? Purely logical. Didn't have any of these pesky emotions bothering us, right? Well, there's a reason we attach, right? It's evolutionary beneficial to us to have close relationships and ties and love with people. So I'll share with you a very sort of reductionistic look at why and how we attach. So I'm going to use my wife as an example. So my wife right now is downstairs in our bedroom, okay? So I know where she is in space. Usually on Thursday night, she's out at St. Mary's University teaching a class, but the semester ended, so she's home. So I know where in space she is, right? Um, I also am, and I'm sure of that. I am 100% sure I know where my wife is right now. I am also quite confident and comfortable that I know how long it would take me to get to her, right? I could go downstairs and look around, and I'd probably be with her in about 10 seconds. If she was at St. Mary's University, I could reliably be with her in 45 minutes. So there's a time relationship in the sense of our attachment. And maybe most importantly, the third quality in really any relationship with something we're attached to is we understand the nature of the relationship. I know what my relationship with my wife is. She drives me crazy. I drive her crazy. But for the most part, she's a pretty good lady, right? So we have a good, solid, loving, close relationship. I understand my relationship with her, right? Now, let's imagine, once again, that 50-year spouse dies on us, right? I don't know where they are, right? I might know where their body is, but I don't know where their spirit or their essence or that which makes them them. I don't know where that is anymore, right? I have no idea when I'll be able to see them again, right? And your spiritual beliefs may have different, sayings or that, but I genuinely don't know when I'm going to see this person again. And maybe the hardest thing to accept is I don't know what our relationship is anymore, right? What is the nature of this relationship now that you've died on me? And folks, when we're unsure, like I said, your brain, among other purposes, is a prediction machine. And we like closed circuits, we like closed loops, we like things to make sense. When things don't make sense, we don't do well. Now, interestingly, these parameters can be localized, not completely, but somewhat, to an area of the brain called the inferior parietal lobule. And you can see it on the screen here. It's kind of a little bit more toward the back of the brain on the left side, not too terribly far from our visual centers, from an area called Wernicke's and the Broca's area, which are involved in language and communication. Now, this inferior parietal lobule, if you get a stroke there are some very interesting clinical findings. You might have a left-right apraxia, which means suddenly you can't tell left from right. Okay, so getting around's real hard. You could have a dressing apraxia, which means if I were to take a jacket and pull a sleeve inside out and hand it to you and say, hey, put that jacket on, you would look at that jacket and say, I have no idea what to do here, right? And maybe even most concerning with these kinds of strokes in this area, you might have what's called a facial agnosia. You don't recognize faces anymore, okay? So your son, your daughter could walk in and say, hi, Dad, and you'd say, yeah, you're not my daughter. You don't look like her. But then you would ask, well, what does your daughter look like? And you'd say, well, I don't know, but it's not her, right? So I guess what I'm getting at is some very complex processes are involved with this part of the brain. And if we stick a grieving person in a brain scanner and we look at what parts of the brains have changed, clearly this inferior parietal lobule ain't working anymore, right? So once more, when people say, I don't know which way is up since my loved one died, they're not messing around. Okay, their brain is really not working. So we've talked about the trace cells in the hippocampus. We've talked about the oxytocin and dopamine in the nucleus accumbens. We've talked about the pain locations in the brain, the anterior cingulate cortex. Now we're talking about the inferior parietal lobule. A whole lot of stuff's messed up, right? Okay, let's look at a real world example. Richard Feynman, right? The Nobel Prize winning physicist back from 1965. He must have been really smart. I don't know what any of that stuff on that stamp means, but hey, he got a stamp, right? So a bright guy. But so he wins the Nobel Prize in physics. But when he was 27 and his darling wife, Arlene, was 25, she died of TB. And he loved her. Everybody knew he was just crazy about her. So I wanted, and after he died, years later, obviously, it was discovered, maybe they found him in a desk drawer or something, he was still writing letters to her years after she died. right? Which again, nobody knew about until after his death. And I wanted to share with you an excerpt from one of those letters. And if you want more letters, there's a ton of, you can go online and Google Richard Feynman's letters. They are absolutely beautiful, right? So let me read this excerpt to you. I know you will assure me that I am foolish and that you want me to have full happiness and don't want to be in my way. I'll bet you are surprised that I don't even have a girlfriend, except you, sweetheart, after 2 years. But you can't help it, darling, nor can I. I don't understand it, for I've met many girls and very nice ones, and I don't want to remain alone. But in 2 or 3 meetings, they all seem ashes. You only are left to me. You are real. My darling wife, I do adore you. I love my wife. My wife is dead. Please excuse me for not mailing this, but I don't know your new address, right? So he clearly demonstrates what we talked about, those dimensions of attachment. He doesn't know where she is in space, right? I don't know your new address, right? He doesn't know where she is in time, right? After 2 years, he still can't get it. And as a matter of fact, he calls the girls he's meeting now the ashes, right? When, I mean, literally, if she were cremated, she's the one who's ashes. But he logically understands she has moved on, she has died. So so again, people struggle when their loved one dies, right? And we just have to be very validating and loving in their current state. So moving on, does anybody know what this is? Yeah, that's a goose egg. That goose egg represents my training in grief during my psychiatric residency. Zero training in grief. We were taught, hey, that's just depression, or it's post-traumatic stress. Again, the expert in the area, Mary Frances O'Connor, I wanted to make sure you saw the title of her book, The Grieving Brain. But the reality is, even the psychiatric profession didn't even recognize grief again until pretty recently. So there's a book called the Diagnostic and Statistical Manual. It's a DSM. And you may have heard of it. It's what mental health professionals use to talk to each other. So if I say somebody's depressed and a therapist says somebody's depressed and the psychology says somebody is depressed, we all know we're talking about the same thing. But in the first 3 editions of that DSM book, there was no mention of grief at all. And that's when I was in my training back in the mid-90s. It was only when the 4th edition, the DSM-4 there, came out in the late 90s, early 2000s, that they at least recognized bereavement, right? Oh yeah, when people die, it matters, right? And then when the DSM-5 was released, I think in 2012, the original description was persistent complex bereavement disorder. And in the most recent text revision, that's what TR means. It's now called prolonged grief disorder. And like I mentioned earlier, the response rates, people do better if you give them grief-specific treatment. And we'll kind of talk about what that is here in a minute. Grief, again, biologically distinct from depression, right? I'd like you to think about depression as a state of amotivation, a state where you're slowed down, a state where you don't want to do anything. Whereas grief is a state of arousal, right? In grief, I want something, I need it, I crave it, I learn it, I'll do anything to get it, right? That's not depression, right? That's agitation, irritability, that sort of thing. And it again comes from that nucleus accumbens, right? That reward center of the brain. The reward center of the brain is hurting when somebody's grieving. Like I said, grief is a motivated process. People will do stuff if it will help resolve some of that yearning. Whereas when we're depressed, we don't want to do anything. Yeah, at all. And again, we're going to use different treatments. I don't want to spend a lot of time on this. The diagnostic criteria for prolonged grief disorder, the loss, this is what we psychiatrists do, right? We put time frames on everything, right? So the loss of someone close considered over 1 year ago or 6 months for adolescents or children. But the key is, again, my profession finally recognized that the grief response is characterized by longing, yearning, or a preoccupation with a person that's passed on. And then the symptoms, and some of these symptoms are kind of weird too. Again, I don't want to spend a whole lot of time on this. There's a disruption of identity. So I have a young lady that I'm treating, I'll call her Jane, I don't know, I'm just making up a name. And her husband died at the hands of a drunk driver about 1 year ago. And we actually just got together yesterday, and she's still a mess. And she said, Dr. Benzick, people are asking me, well, what do you want to do for the rest of your life? What do you like to do? How do you want the house to look? And she said, Dr. Benzick, I cannot imagine myself not in that couplehood that I had with my husband. So her individual identity has been markedly disrupted. Maybe disbelief about the death, avoidance of reminders that people have died. Sometimes it's very difficult to get them to sort of accept that the death has occurred. 4 and 6 are sort of opposite of each other, showing the individuality that you see in grief. Some people have very intense emotional pain. The 5th is difficulty reintegrating into life. Well, they wouldn't be coming to my attention if they didn't have difficulty. Number 6 is emotional numbness, right? That's kind of the opposite of number 4, just showing that people have all kinds of emotional responses when they're grieving. A feeling maybe that life is meaningless. We always have to ask about suicide and moving forward and that sort of thing. And then again, these two are kind of a opposite of each other. Some people have a loneliness, right? I'm lonely, I need some people. And other people have a sense of detachment. They don't want to be around anybody. Bottom line is, we're kind of a mess, right? Because our brain's not working. So what do we do? How do we help, right? Grief targeted talk therapy has been shown very successful in walking with somebody through this process to address specifically how has their relationship changed. One of the things I like to remind people when their loved one has died is that you still have a relationship with them. In fact, I always ask, are you still talking to so-and-so, grandma, grandpa, your dad? I still talk to my dad. He died a couple of years ago. My mom still talks to her mom, right? My mom's 80 and she still talks to her mom, and we still have a relationship. It's just not going to be the same. And people need help with that, right? We want to address that avoidance, right? Which can at times be somewhat delusional. This is really important. It's really important we address the would'ves and the should'ves and the could'ves, right? Because how often will somebody grieving say, if I would have gotten there sooner, or if I would have just responded when I heard them yelp a little bit, or I could have told them to stop smoking sooner. But the problem with that is that sentence always ends up with, and then they wouldn't have died, right? And that's just not realistic in so many cases. And it's important that these people work on, as it says there, the new narrative, right? What is the reality, the narrative around maybe how that person died, when they died, and what's the new story of your life going to look like? And often people need their hand held while they walk through that. We've talked about the different parts of the brain that aren't working right. We talked about, again, the hippocampus and the trace cells. We talked about the anterior cingulate gyrus and the pain. We talked about the nucleus accumbens, the reward center. And we certainly talked about the inferior parietal lobule and all the different facets that that's involved with. So those parts of the brain aren't working. So we want people to stick to their routines. Hey, if you can still go to work, you go to work. If you met with your buddies for coffee every morning, you keep trying to go meet your buddies for coffee every morning. While certain parts of the brain aren't working their best, we want to strengthen those parts that are. If you exercise every day, keep exercising. Get back into your routines. That was the best advice, frankly, I got when my dad passed away. So again, do we throw medications at these folks? Absolutely not. The young lady that I just described, whose husband was killed by the drunk driver, I saw her yesterday and we both agreed this isn't about medication, right? In fact, the only medication that I provided to her was for when she couldn't sleep, right? So for her symptoms. And because she's going to be involved in some depositions, right? Drunk driver, criminal stuff, civil suits. So I gave her some medicine for those symptoms, but antidepressants, again, are not traditionally the answer from this. In fact, maybe the best advice I got in my whole residency training was never deprive your patient of the opportunity to cry, right? And some of the medications can be fairly numbing. And then maybe the most important thing, and I'm going to leave you with this, is that we approach these folks with knowing what we know neurobiologically. Let's approach them with a different question. We're not going to ask, how are you doing? Because we know how they're doing. They suck, right? They hurt, they're confused, they're miserable, they can't sleep, right? Let's not ask them, how are you doing? Let's ask them, what have you learned since your loved one died? So I treat an attorney, and I'm making up a name. His name is Robert, and a super nice guy. And his father recently died, and his father, in his 80s, I think, was like the town doctor back in the small town he grew up. and I think was mayor for a while, and like president of the Kiwanis Club or whatever, Rotarians or whatever it was. Really, really well respected in the community. Didn't have a whole lot of time for Robert, right? But Robert loved his dad. He is pretty sure his dad loved him. And Robert's having a hard time. And just a couple of weeks ago, I asked Robert, he was in my office, and I said, well, Robert, what have you learned since your dad died? And he looked at me with this blank stare, like, and I didn't know what was going on. I thought he had a stroke or something. I mean, I was like, well, Robert, you there? He said, I hadn't thought about what I learned since my dad died. And I said, well, I can tell you what I've learned since your dad died. I learned you really loved your dad. I learned you wish you would have been able to spend more time with him. I learned that you want your relationship with your children to be better than that you had with your own father. I've learned you really respected your dad, and you admire his hard work, and you've really tried to honor him with that every day when you go run your practice. And I think I said 5 or 6 other things. And he was just so relieved by the end of the session. He said, you've really given me something to think about here. So that's what I got, folks. I can, again, here for questions. I can answer the best I can. Again, no certainly grief expert, but I do think I have a little bit of knowledge in this since I've been studying it for a couple of years. So, yeah.
Well, thank you. That was fabulous. Jeff, I did have a question though. Does grief go into depression if left untreated, or how often does that happen?
So great question, because it actually doesn't. Remember, depression is a pathological state, right? Depression is a state of like sickness. Grief is a state of being human, right? Grief is a state of humanity. Grief is a state of that shows what do we talk about at ABODE, right? That's the final act of love, right? So the fact that when a loved one dies and you can't sleep and you can't eat, and I tell people, look, it means you're doing it right. It means you're doing the grief thing right. Now, can it go into depression? Absolutely. So as I'm navigating this journey with people, what I'll often ask is, hey, how are you feeling about you, right? How do you feel about yourself? And if they say, what are you talking about? I'm fine. I miss my mom. It's like, okay, you're good. But if they start getting into that whole, we call it Beck's triad. It's a very famous triad of psychological symptoms, and I'm paraphrasing, but in summary, the 3 symptoms are I suck, the world sucks, and it's always going to be like this, right? If when I'm working with somebody with grief and they start talking about themselves and getting down on themselves and maybe what a lousy person they are, okay, then we're crossing a line, right? If there's a sense of, and I want to hurt myself to go be with that person, we're crossing a line, right? If they appear to be losing touch with reality, we're crossing a line. That's actually not all that common. Most people just need, time and healing and love and understanding and, a caring ear.
Yeah. And like Peg said last week, I'm just going to listen. I'm just going to sit and listen. She went on about how, and a lot of this makes so much sense because last week she was talking about people love to tell the story. And they want to come in and talk about their loved one, and their friends and family are tired of it. And so, as their therapist, she would sit and listen, and they could tell the story 100 times and listen to how it changed. And she could tell how they were progressing through their grief. And
people might seem to appreciate kind of that very gentle command. Tell me how I can best help you. Right? Everybody's an individual, and they might say, yeah, I just need to talk, right? Or, I need something to help me sleep or whatever. Hey, Dr. Benzick, I need a group. And I say, well, I know this place called the ABODE home. They got groups. But yeah, just again, like I said, I think that's another very important point. Again, grief is not pathologic. Grief is being human, right? Yeah. Depression is pathology. Something's wrong, and that needs to be treated.
I loved what you said about not medicating folks so often. And we have a guest now, and it hurts my heart because she is seems to be in such discomfort. She always has a pained look on her face. And, on the one hand, I feel like, well, let's give her a little something, something to make her feel better. But on the other hand, maybe she's just grieving that she knows she's dying and she's sad. And let her moan.
Mhm.
Well,
And it's the fact that she doesn't want to take pain medicine, almost like
wow.
she wants to be in it,
Do I see a hand up there, Aspen?
Yes, thank you. That was so helpful. I wanted to ask, I have a brother who I describe him as having severe PTSD because of unremitting grief. He was present when my other brother crashed in an ultralight. Obviously, after 21 years, that is getting into something clinical, but he refuses. Is it correct to describe it as PTSD, or is it just this prolonged grief syndrome?
Wow, that's a great question. I think it would sort of, if we have to give it a name, and that was something I learned in the Air Force. We don't diagnose somebody with what we can. We diagnose somebody with what we have to diagnose them with, right? So, if he's got some very specific post-traumatic stress disorder type symptoms, there's four big categories, right? There's avoidance symptoms, right? There's re-experiencing, like nightmares and flashbacks and things. If there are what we call hyperautonomic symptoms, like being jumpy, can't sit with my back to the door, hypervigilant. And then if there's mood symptoms, and if there's all four, I would say, again, given especially the duration of that, I think that'd be better characterized as post-traumatic stress.
Yes, sir. Okay, that hits all four for him.
Okay.
And one follow-up question, if I could, I don't know if this is an appropriate place to ask, but Johns Hopkins and other places are using psilocybin research with PTSD
Sure.
patients, and this seems to be working incredibly well. Would this be appropriate for someone with just years and years long grief, or that would perhaps not be an appropriate area? And thank you.
Believe it or not, folks, psilocybin's really safe, right? If you actually look at the potential side effects of things like psilocybin versus, oh my gosh, some of the antipsychotic medications we prescribe and all that, in general, psilocybin's really safe. Now, it's not FDA approved. I'm not saying go out and get psilocybin. That's coming. I genuinely believe that, and it's got to be administered in the proper setting. But not seeing a whole lot of downside, right, for situations like this. So yeah, I think keeping your eye out for what's coming down the pipe in terms of research and what's available. If I had a family member suffering like that, you bet I'd sure be thinking about, hey, would something like psilocybin in the future, when it's available, be appropriate? Absolutely, I'd be thinking about it.
Thank you so much.
You bet.
Viv?
Yeah, thank you. I was curious, you talked about the value of talk therapy, and you talked about the sort of creation of the new narrative. And I'm wondering if you know much about ways that writing or art or other modalities are being used, and the value of that in that, because the idea of creating the new story of your life really resonated for me as somebody who teaches writing. And I'm just curious if you know much about what's being done in that world.
Oh, there's a ton on that, especially with things like journaling, right? The reality is when we write something down, we use clearly different parts of our brain than if we're just sort of thinking about a story, or if we're actually just saying the story. And I'm not sure about the literature between typing and handwriting. My understanding is handwriting is better. Honestly, you need more fine motor skills and things like that. But I mean, and that wisdom's been around a long time. What's the it's one of the later prophets in the Bible, Habakkuk, I can never pronounce the name right, but in the second chapter, it says, hey, write your question on stone tablets and you will be given an answer. Right? Yeah. So yeah, I'm a big fan of journaling, and without question, writing things down absolutely helps that narrative move forward. And again, anything that can incorporate more emotion, more emotionality, more creativity, like art therapy, music therapy, again, it's all part of that healing process.
Yeah, thank you.
Sure.
Andy, you had a question?
Yeah, I don't want to make this a personal therapy session, and if what I'm asking does not have general applicability, then I'll take it somewhere else. But my personal experience with grief, and I've had two really bad grief experiences in my life. My parents both died suddenly. My experience with grief is I felt like my brain was actually disconnected, unwired. I felt like my head was empty. There were air bubbles in my head that weren't places where my brain just no longer existed. And I was disoriented and unmotivated, and I was kind of lost. At one point, I was a squadron commander when my mother died.
Sure.
And my first sergeant said, "We just kind of led you around for 6 months and then you were okay again." So is that that doesn't seem to fit with what you've explained, and I'm curious, is that
Well,
unusual?
It's interesting that you say it, because to me, it fits exactly with what we talked about today. That so many different areas of your brain were just not jiving, right? That especially again, that inferior parietal lobule, where we really make sense of a whole lot of things, it just wasn't working. Right? So it sounds like, yeah, for 6 months the lights were on, but nobody was home.
That's exactly right.
Yeah.
The lights were on,
Yeah,
but nobody was on.
That makes perfect sense. Again, talking about all these different brain regions just not firing as they would normally. Your brain just wasn't working its best.
Yeah, it was almost like looking, like when you try to read Hebrew if you're not Jewish. You look at a Hebrew character and nothing happens in your brain. You look at an A and you hear A. You look at an X and you say X. You look at a Hebrew character and nothing happens. And the whole world was like that for me. Nothing was firing.
Well, so what's interesting though is that it sounds like you were still getting up and going to work every day.
Well, yeah, I was a squadron commander.
You're a squadron commander. So again, notice in all the stuff that I talked about, it didn't mention anything about there being a problem in the frontal lobes, right? The frontal lobes are this very anterior part of the brain.
Yeah.
And this is where we do the day-to-day stuff, right? So all that is operational, right? So you're getting up and, doing what you have to do as a squadron commander, but emotionally and really, cognitively and sort of primitively, you weren't doing so well. Just
No.
that detachment from life. But yeah, get up, put your uniform on, put it on properly, get to, get the duty day starts at 0700, you're there.
And you didn't have to pick out anything to wear.
No.
Routines. So thank you for saying that, Beverly, because again, the rote stuff, the easy stuff, after a while when you're in the Air Force, of course you get up and put your uniform on. You've got it ready there the night before. You've every night you've been getting it ready for 10, 15, 20 years, whatever. Yeah, you don't even have to think about it anymore. So yeah, that part's easy.
Mm-hmm.
Okay, thanks.
You got it.
We always hear this, that there's no timeline for grief. When do you start to worry about folks?
Yeah, I really
5-year mark.
Yeah, maybe like 3-5 years.
Mm-hmm.
Japanese culture, I believe it's 3 years. That's like standard for grief. All these cultures around the world, it's years, right? Some of my poor patients, their spouse dies, and a month later, hey, can I set you up with somebody? It's our McDonald's culture is just fascinating, isn't it? Right? But yeah, I start to worry if it starts to look pathologic, if there's a risk of danger to somebody, if their sense of self is involved, if there's any psychotic kind of symptoms. But for the most part, like my young lady that I mentioned, yesterday, she's really doing her best. She goes to a widows group. She gets out with her family some. So am I worried about her? Well, I'm worried the way that a person who cares about somebody else worries about them. But in terms of, do I think that she's losing it? No, she's grieving.
What about a death that is sudden, like the woman you were talking of? Her husband just dies suddenly, or a loved one who, gets a terminal disease and you watch them die, and each one of them has their benefit, you tear the Band-Aid off really quick and you can start healing, or, this slow progression. Do you see much of a difference in the grief between the two?
I really haven't. I think there's maybe a longer sense of disbelief right after the sudden stuff.
Mhm.
But in terms of the actual grief, okay, excuse me, I understand they've died. They're I have to understand that they died and I have to move forward. Not really. And interesting, so it's such an interesting point because in all the stuff that I read to get ready for this talk, it just didn't come up. It really didn't come up. Yeah, and I was very surprised by that, but I didn't see a whole lot.
Wow. Yeah, I like what Mackenzie wrote here. She said, I went to feed my dog the other day and she's been gone for nearly 2 months now.
Yeah.
Sometimes grief really shocks me.
You summed it up very nicely, mush. Yeah, the brain
Mhm.
is mush.
Yeah.
And again, I tell people, and that's normal. So there's a wonderful book called Self-Compassion. And I'm blanking on the name, it'll come to me here in a second. But it was written by an author, gosh, she's a professor at the University of Texas, Kristen Neff, N-E-F-F, Kristen Neff. And the book is just called Self-Compassion. And so I have a copy of that and I leave it right on the coffee table in my office, right in front of the patient. And it's always there 24/7 because I want people to see it, because we're not compassionate enough with ourselves. We put too much pressure on ourselves. Hey, I'm not doing this fast enough. Why can't I get over this? That sort of thing. And when I start hearing that from people, I just reach down and I pick up the book and I say, please go get a copy of this.
When in those occasions when I've been dealing with people who are grieving, based on my experience, which I am now validated for, thank you. The first thing I say to them is, be easy on yourself. Be gentle with yourself. Relax. The only way out is through, but you can either stress or you can just walk through it gently. And people seem to connect with that and find it useful.
For sure. For sure.
Am I
Yeah.
am I outside the reservation here?
I tell people, look, because they'll get on themselves about not exercising, and I'll say, look, your exercise someday may be, instead of laying in bed all day, you got up and threw your feet over the side of the bed, right? That might be your exercise some days. Yeah. And I'll take it.
Just little steps forward. Yeah. Well, it's 7:30, so our hour is ending. Thank you, Dr. Besnick. We love this. It was
Oh, my pleasure.
perfect. It was perfect. And I hope y'all learned something. What'll be wonderful is to take some of these things we learned tonight. Next week is our last installment of ABODE Academy on grief. And I'm going to have 3 of my patients' widows with us. And each one is on a different point in their grief journey. And so it'll be interesting to hear their insights and what they've learned, what grief, how it surprised them, what did they experience. And so I hope to see you all there next Thursday night, 6:30, and bring questions. Yeah, this will be very, very interesting to apply what we've learned tonight and last week with Peg. And then I'm just going to throw it out again. The art shows this weekend on Saturday evening from 5 to 8 at the Church of Reconciliation. And then again, Sunday morning, if you can't make it Saturday night, from 10 to 1 on Sunday morning. Come by and just visit, say hi, look at some art. We'd love to see you. All right. Anything else, Mary?
If this session has blessed you in any way, feel free to visit abodehome.org/donate. We run completely on donations and grants at Abode, and we appreciate you sharing some love.
Thank you. Thank you,
Thanks,
Dr. Jeff.
Dr. Jeff.
Have a wonderful evening, everyone, and we'll see you next week.